My name is Dr. Toibat Egbeyemi. I work at First Cardiology Consultants, and today I'll be talking about the European Society of Cardiology's guidelines on the management of hypertension, specifically the 2024 guidelines, which is the most recent one at the moment. So I'm going to talk about the definition of hypertension, how to diagnose hypertension, the current treatment guidelines, and then specific patient groups to consider when treating people with hypertension, acute management in cases like hypertensive emergency, hypertensive urgency, and stroke. And then I would conclude the presentation. What is hypertension? Hypertension refers to persistently elevated blood pressure, and it's very important we understand how to diagnose and treat hypertension because it is one of the most important modifiable and treatable factor in cardiovascular related deaths. Now, according to the European Society of Cardiology, blood pressure is divided into normal blood pressure, elevated blood pressure, and then frank hypertension. Normal blood pressure, as we can see on the screen, is blood pressure that is less than 120/70. And elevated blood pressure is when it's between 120 to 139/70 to 89. And then hypertension is blood pressure that is greater than or equal to 140/90. Now, how do we diagnose hypertension? Hypertension can either be diagnosed in the office. So office refers to clinical setting, at home either using a home blood pressure monitor or 24-hour ambulatory blood pressure device. So that's when we give our patients an ambulatory blood pressure monitoring device, and then it will take readings, both daytime and nighttime readings, over 24 hours. And then we'll use an average of those readings to diagnose hypertension. Home blood pressure monitoring, on the other hand, if a patient finds that they have elevated blood pressure, or so if their blood pressure is very high, if it's more than between 120 to 139, or if they find that it's more than 140, they'll be advised to take morning and evening readings of their blood pressure. And then we'll take an average of those readings and use that to diagnose hypertension. Now, why these two methods of measuring blood pressure are very important is because they're able to detect white coat and masked hypertension. With white coat hypertension, patients would visit the clinic, find that they have high blood pressure, and then when they get home, the blood pressure is low, or it's normal at home. Now, this can be because of reasons like being anxious in a clinic setting. That way, if a patient takes home blood pressure monitoring, we can detect white coat hypertension. So white coat hypertension will be able to manifest itself. Masked hypertension, on the other hand, is when a patient visits a clinic setting, finds that they have normal blood pressure, and then when they measure their blood pressure at home, they find that it's high. This is common among patients who might have more stressful situations at home. And if we ignore or neglect white coat and masked hypertension by only taking clinic readings, it can cause us to overtreat or undertreat patients respectively. If home blood pressure or 24-hour ambulatory blood pressure measurement is not feasible, we can use office readings to diagnose hypertension. However, a patient is going to need an additional clinic visit for us to be able to confirm the diagnosis of hypertension. This slide shows the different thresholds for diagnosing hypertension, elevated blood pressure, and elevated blood pressure in the office, that's a clinic setting, at home, or using ambulatory blood pressure monitoring. Now, as you can see, we have daytime readings for ambulatory blood pressure monitoring, and we also have nighttime readings as well. The significance of nighttime readings is it has to do with something we call physiological nocturnal dipping, where every individual's blood pressure is expected to dip to be lower at night. The threshold is lower for nighttime readings. So if you have an individual that doesn't experience nocturnal dipping, or if they experience reverse dipping where their blood pressure is higher at night, these individuals are more at risk. So they have a higher cardiovascular risk than someone who has the regular pattern of daytime reading being higher than nighttime reading. And it can also inform us about, can give clues to obstructive sleep apnea when the nighttime reading is higher. And it can also help us to guide management. So there is a concept called chronotopy where we can guide medication. So medication can be timed to a certain time of the day. If you find out that someone has blood pressure that is higher at night, we can prescribe for them to use their medications at night to help with that, as opposed to any time of the day. Now, what is the next step after diagnosing hypertension? These are the routine tests. This slide is showing the routine tests recommended after hypertension is diagnosed. The importance of doing these routine tests is, first, we'll be able to manage comorbidities associated with hypertension. Comorbidities like diabetes, hyperlipidemia, chronic kidney disease, and that way we'll be able to reduce overall cardiovascular risk. Secondly, doing routine tests can help us guide treatment. It can guide treatment in terms of the decision to initiate treatment in someone with elevated blood pressure. It can inform us on the presence of hypertension mediated organ damage, which can also help us to determine or decide if we should intensify treatment or not. Then, in addition to these routine tests, it's also recommended that we test patients for orthostatic hypotension at diagnosis. In orthostatic hypotension, patients is asked to lie supine, and when they stand, so we measure their blood pressure when they are supine and when they stand. And if it's more than 20/10, if there's a difference, it means they have orthostatic hypotension. Among people with orthostatic hypotension, we would usually want to start with monotherapy, and treatment is less aggressive. So this information on orthostatic hypotension is important at diagnosis. Also, echocardiography, while it's not a routine test, if our patient has abnormal rhythms on a 12-lead ECG, or if we detect murmurs or any cardiac symptoms at diagnosis, we would further do an echocardiography. Next, we're going to go into the treatment guidelines. When someone is diagnosed with hypertension, they typically have a more than 10% 10-year risk of adverse cardiovascular outcomes. And among individuals with elevated blood pressure, some of them have the same risk as people with hypertension. Therefore, it's a disservice to people with elevated blood pressure to assume that they don't have this risk like someone with frank hypertension. So we'll just recommend lifestyle measures and let them go. So this is why we have a concept called risk stratification among people with elevated blood pressure. Now, the importance of risk stratification is to find out who has this 10% 10-year risk. So the people with high cardiovascular risk among people with elevated blood pressure, and therefore determine who we are going to treat or initiate pharmacological treatment with. This slide is showing the risk stratification process for people with elevated blood pressure. Now, when someone is diagnosed with elevated blood pressure, that's blood pressure between 120 to 139 over 70 to 79. First question would ask is, do they have high cardiovascular risk conditions? So do they have moderate or severe CKD? Do they have hypertension mediated organ damage? Do they have type 1 or type 2 diabetes mellitus? Do they have signs of established cardiovascular disease like previous myocardial infarction, for instance? And do they have familial hypercholesterolemia? This applies to an individual with elevated blood pressure. They are classed as being high risk automatically. Now, among people with these high cardiovascular risk conditions, if someone has only diabetes mellitus and they are less than 60 years old, we are going to do a systemic coronary evaluation through diabetes scoring for them to be able to, because among people with diabetes that are less than 60, their risk is not the same as people who are more than 60. So we need to further determine their risk with this scoring. Now, if none of these applies to someone with elevated blood pressure, we'll go on to do the SCOR2 testing. So this is the systemic coronary evaluation scoring. It's a formal scoring. It's a formal scoring to determine cardiovascular risk in people. Now, if you go online and you click SCOR2 calculator, the calculator is going to come out, and then you'll be able to input your patient's details in that calculator, and then you get a score. So cardiovascular risk can be 2%, for instance, or it can be more than 10% when you calculate. If your patient's risk is more than 10%, patient is classified as high risk. Now, of note is the fact that score 2 OP refers to scoring for older persons. If your patient is more than 70, we would use the score 2 older persons. And then this score 2 here is for patients that are between the ages of 40 to 65. If a patient has borderline score, so between more than 5% but less than 10%, we would bring in the concept of risk modifiers. Now, what are risk modifiers? Risk modifiers are additional, they are non traditional risk factors. Traditional risk factors for cardiovascular disease include weight gain or obesity, excessive alcohol intake. Those are traditional risk factors. Risk modifiers are non-traditional risk factors that would tip someone from being borderline, having a borderline cardiovascular disease risk to a high risk. And we have shared risk modifiers. Those are modifiers that apply to both men and women. So, for instance, if someone has a borderline SCOR2 risk and they are of high risk ethnicity, we need to strongly consider initiating them on pharmacological therapy after 3 months of lifestyle measures. Or if someone is socioeconomically deprived, we know that people who are socioeconomically deprived have less access to healthcare systems. They are more likely to have poor diets. They are more likely to have low health literacy, which can lead them to making less healthy choices. So we strongly consider initiating pharmacological treatments as well. Or people with autoimmune inflammatory conditions and HIV who are in a state of chronic inflammation, which can put them at risk of endothelial damage and atherosclerosis as well. We also know that people with severe mental illnesses, through the use of antipsychotics, they may gain weight or have metabolic syndrome when they use certain antipsychotics. So we strongly consider putting them on pharmacological treatments. Now, with sex specific modifiers, these are also additional risk factors among women that will make us strongly consider them on pharmacological treatments. Now, back to this slide. If we apply, if someone has borderline risk and we apply a risk modifier and it's positive, so they have one or more risk modifiers, or anyone that already had automatic high risk by having any of these high cardiovascular risk conditions, or someone that had a more than 10% cardiovascular risk, we'll put them on lifestyle measures for 3 months. And then we'll reassess them in 3 months. We'll check their blood pressure again and also reassess their cardiovascular risk. If their blood pressure is still more than 130/80 and they're still high risk, we're going to initiate monotherapy. However, if someone has frank hypertension, that's blood pressure that is greater than or equal to 140/90, we'll initiate lifestyle measures immediately and put them on double combination therapy. Now, what are these lifestyle measures? As you can see, we have different lifestyle measures on the screen: sodium restriction, weight loss, smoking cessation, alcohol intake, physical activity, limiting free sugar consumption, and increasing potassium intake. Of note with weight loss is the fact that weight loss is an important lifestyle measure, and it's been found that studies have found that an average weight loss of 5 kilogram correlates with a reduction of up to 4.4 over 3.6 of systolic and diastolic blood pressure, respectively. With smoking cessation, we will not have a direct reduction in blood pressure. So if you advise your patient to stop smoking, it doesn't mean an automatic decrease in blood pressure rather. However, smoking is going to reduce our patient's cardiovascular disease risk. With alcohol intake, while it's fine to avoid going below this upper limit on the screen, if a patient can totally stay off alcohol, that is much more beneficial. Physical activity. In physical activity, aerobic exercise is what is commonly recommended. However, in addition to aerobic exercise, it's been found that in non-white patients, so this includes black patients as well, dynamic resistance training is just as effective as aerobic exercise in preventing in reducing cardiovascular disease risk and reducing blood pressure as well. Therefore, when we want to advise our patients, in addition to advising aerobic exercise, so moderate physical activity, we can advise them to complement it with strength training as well, 2 to 3 times a week, depending on how capable they are on their strength levels and physical limitations as well. Also, when it comes to limiting free sugar consumption, this especially applies to sweetened beverages, so reducing our intake of sweetened beverages. And while increasing potassium intake is beneficial as well, we should also be cautious when our patients have moderate to severe chronic kidney disease, or if they are on angiotensin inhibitors or angiotensin receptor blockers as well. So, with regards to weight loss, if we want to prescribe weight loss medications to our patients, semaglutide, also known as Ozempic, has been shown to be beneficial in reducing blood pressure compared to other weight loss medications. What are the now after our patients are diagnosed with a hypertension and want to initiate pharmacological treatment? The next question is which medications are best suited for our patients, and this also applies to Black patients as well in this part of the world. The first line medications are angiotensin converting enzyme inhibitors or angiotensin receptor blockers, dihydropyridine calcium channel blockers, and then diuretics, specifically thiazide and thiazide-like diuretics such as hydrochlorothiazide, clothalidone, and indapamide. Specifically, among Black patients, calcium channel blockers have been shown to be superior to other medications in reducing blood pressure in Black patients. So if there are no contraindications, it is highly recommended that calcium channel blockers be included as part of the medications we prescribe before we then prescribe other medications, other first line medications rather. So it should be calcium channel blockers and then maybe angiotensin converting enzyme inhibitors or ARBs or calcium channel blockers with a diuretic, depending on what specific indication applies to our patients. These are the different drug classes and examples for the drug classes. We always prefer single pill combinations. When we want to start our patients on double combination or triple combination therapy, it's preferred that we, as much as possible, use single pill combinations. And these are some of the examples of simple single pill combinations available. We have Xforge, Twin Star, or Diovan. So this, for instance, is Xforge consists of a calcium channel blocker and an ARB, or Twin Star, a calcium channel blocker and an ARB telmisartan as well, or valsartan HCT and ARB, nitazide diuretic. This slide is showing the algorithm we can use to guide treatment among our patients with hypertension. Now we'll start with a low dose double combination therapy, and it can be any of these first line medications as was mentioned earlier. We assess our patients after 1 to 3 months. If the blood pressure is controlled, it's sufficient to follow up at least every year. However, if their blood pressure is not controlled within this 1 to 3 months of follow up, put them on a low dose triple combination therapy. Now, a question that might come up is why not increase double combination therapy instead of going straight to triple combination therapy? As we know, with hypertension, there are multiple mechanisms involved in causing hypertension, from the RAS pathway to salt or water retention. So, by using multiple medications, we're able to target different pathways, and that will give a better effect or better effectiveness when it comes to reducing blood pressure. If we reassess our patients and blood pressure is still not controlled, then we go to maximally tolerated triple combination therapy. Reassess if blood pressure is controlled, that's fine. However, if it's not, then we'll consider adding a mineralocorticoid agonist like spironolactone and then work up our patient for resistant hypertension, which we'll go into in the next slide. Now, alternative fourth line medications apart from spironolactone include eplerenone, also a mineralocorticoid agonist, beta blockers, centrally acting medications, alpha blockers like doxazosin, or hydralazine. So we can consider these. However, while these are referred to as fourth line, if at any point in time there's an indication to use any of these medications, we should not hesitate to add them. For instance, we may add beta blockers at any step if there are compelling indications like angina, post myocardial infarction, systolic heart failure, or heart rate control. Or you may add alpha blockers if, for instance, someone has benign prostatic hyperplasia. You can prescribe doxazosin as well. Now, we mentioned resistant hypertension briefly, and to elaborate on that, this is when we've used all the treatment strategies. So we've used both lifestyle measures and the maximally tolerated doses of triple combination therapy, and this has failed to lower systolic and diastolic values to the target blood pressure. Now, when a patient presents with resistant hypertension, we need to ask critical questions. Are they adhering to lifestyle measures? Are they adhering to the adequate doses of their medications? Do they have white coat hypertension, or are there secondary causes of hypertension like primary aldosteronism or obstructive sleep apnea we might have missed? And also, the possibility of white coat hypertension is why, when patients have hypertension, it's important to ensure that they continue to take home blood pressure measurements at home so you can compare this to the clinic measurements. Now, when a patient has resistant hypertension, if you suspect secondary causes, they can be referred to the right specialists, like endocrinologists, for instance. Treatment targets in hypertension. Now, what blood pressure are we trying to achieve when we put our patients on medication? The treatment targets in both hypertension and elevated blood pressure. Our aim is 120 to 129 over 70 to 79. While we'll try, the exception to this rather is pregnancy, where it's less than 140/90. We also try to be lenient when it comes to frail patients who are more than or equal to 85 years old, or patients with orthostatic hypotension. In this group of people, you try to achieve as low as you can. So that's the principle we use for trying to get a specific target. Now, we've dealt with hypertension in conventional hypertension, so in a patient with no comorbidity, that has primary hypertension. Now, how about specific groups of people? Among pregnant people, for instance, the first line is different. First line includes calcium channel blockers, labetalol and methyl because these are medications that have been shown to be safe in pregnancy. So there have been extensive research and safety has been shown among these. Angiotensin enzyme inhibitors, on the other hand, and angiotensin receptor blockers are contraindicated because they have been shown to be teratogenic. Specifically, they are able to cause renal defects in the fetus. Beta blockers as well have been shown to cause fetal growth restriction as well. Then in people that are 85, that are frail people are people who are partially or completely dependent on people for activities of daily living, someone who is terminally ill with reduced life expectancy. We prefer to use calcium channel blockers or ARBs or ACE inhibitors first. And this is because this group of people have reduced physiological response and they have blunted response to thirst. So they are more prone to dehydration and electrolyte imbalances than other people. So this puts them at risk of falls as well. So we always like to start with monotherapy as well in this group of people to avoid aggressive treatment. Now, people with pre-diabetes or diabetes, ACE inhibitors and ARBs are first line because people with diabetes tend to have albuminuria and ACE inhibitors are usually protective. And they also help to delay new onset diabetes among people with pre-diabetes. Among people with chronic kidney disease, it is also beneficial to add SGLT2 inhibitors if their eGFR is, of course, more than 20 mils per minute. This is because SGLT2 inhibitors have been shown to be renal protective as well. And they also have a moderate effect when it comes to reducing blood pressure. With thiazide diuretics, we would usually not use them unless the eGFR is more than 30 mils per minute. And that's because at this eGFR, there is less filtration to the distal convoluted tubule where thiazide diuretics tend to work. So at eGFR less than 30 mils per minute, that is, you have less filtration. So they might not be very effective at that point. In heart failure, there are conventional medications recommended in heart failure, and it's preferred that we use those in people with heart failure. Calcium channel blockers, we need to be careful because they can reduce contractility, especially the non-dihydropyridine ones. In people with previous myocardial infarction, beta blockers, ACE inhibitors are preferred. ACE inhibitors can help improve LV function. And with symptomatic angina, we prefer beta blockers and calcium channel blockers because they can help improve myocardial oxygen demand and alleviate symptoms in symptomatic angina. So far, we have spoken about hypertension. So, hypertension as a chronic disease. Now, what happens when we have acute crisis in hypertension? One of these is hypertensive emergency. And this is when the blood pressure is more than or equal to 180 over 110. And this is usually associated with acute hypertension mediated organ damage. So, person has very high blood pressure with stroke or comes in heart failure, aortic dissection, myocardial infarction. And hypertensive emergency, as a result, usually comes with symptoms. So, there may be symptoms of dizziness, chest pain in line with the organ damage that is occurring. What we do in this situation is, of course, after stabilizing the patient, the mainstay of treatment when it comes to bringing down the blood pressure is IV labetalol. Other options are IV nicardipine or IV esmolol as well. And with labetalol, we'll give 20 milligrams IV over 2 minutes. Then you can give 40 to 80 every 10 minutes as needed and not to exceed a maximum dose of 300 milligrams. An alternative is you can, if the blood pressure is still not controlled, you can do an infusion of 1 to 2 milligrams per minute after you must have given the bolus dose. For hypertensive urgency, on the other hand, the blood pressure is very high, just as high as it was in emergency. However, there is no clinical evidence of organ damage. In this situation, patients do not need to be admitted, and it's sufficient to use a short acting oral medication like captopril or labetalol, and then repeat into hours as the patient needs. So while you're monitoring the blood pressure, patients can go home and they will give them a short follow up in about a week. Now, lastly, we are going to talk about acute management of blood pressure in stroke. So we have ischemic stroke and we have hemorrhagic stroke. In ischemic stroke, we already have limited perfusion to the brain. So when you don't plan to do IV thrombolysis or thrombectomy in ischemic stroke, it is advised that you don't reduce the blood pressure, or unless the blood pressure is more than 220 or 120, that is, unless the blood pressure is very high. However, if you plan to do IV thrombolysis or thrombectomy, which puts the patient at risk of bleeding, in order to prevent any expanding hematoma, we want to reduce the blood pressure slightly, but still not too much. So with thrombolysis, you're looking at reducing the blood pressure to less than 185 over 110. And then you maintain it at 180, 105 over 24 hours. With thrombectomy, you reduce it to less than 180 over 105 and also maintain it at this blood pressure over 24 hours. With hemorrhagic stroke, on the other hand, we want to reduce the blood pressure, but we shouldn't reduce it by more than 70 millimeters of mercury, and reduction should be slowly. And we'll aim for a range of between 140 to 160. And the point of this is also to prevent expanding hematoma in hemorrhagic stroke. Finally, we'll talk about monitoring and follow up of patients with hypertension. Now, we can follow patients up within 1 to 3 months, and the patients who require short follow up are a patient who we still want to confirm hypertension or elevated blood pressure. So, if a patient has come to a health facility and opportunistically we detect high blood pressure, we would ask them to come back within a month. So, if they have access to home blood pressure monitoring, they will be taking their readings over this period of time. Come back to the health facility, we'll take an average of those readings and be able to confirm or diagnose hypertension. Or if it's office blood pressure measurements, they can come back, would remeasure in a subsequent clinic visit and be able to confirm hypertension. If a patient is struggling with controlling hypertension, a patient is uncontrolled hypertension, would also ask them to come back within 1 to 3 months. So giving at least 1 month in between would allow for, if we've altered or adjusted their medications, this will allow for the medications to work, because it's been found that it takes at least 2 weeks for antihypertensives to work. So this will allow time to see if the new medication is working and if we need to make further adjustments. 3 months follow up will be ideal for a patient with elevated blood pressure and that has high CVD risk, as we mentioned earlier. So this kind of patients would have told them to go and do lifestyle measures for 3 months, and they want them to come back after 3 months. For other people with controlled hypertension or a patient with elevated blood pressure and low CVD risk, yearly follow up is adequate for this set of people. Now, what are the parameters we're looking at during follow up? During follow up, you want to measure their blood pressure and also compare it to their home readings. Take a history and physical examination for any new symptoms. You want to reassess their cardiovascular risk, see if there is any hypertension mediated organ damage that we need to address. Ask them about their medication adherence, if there are any challenges, any side effects from medications as well. If to know if you need to change their medication, see if their weight has changed. This can tell you if they are adhering to their lifestyle measures like eating a healthy diet, physical activity, or weight loss as well. So in conclusion, we've spoken about hypertension, how hypertension is diagnosed, the treatment guidelines of hypertension, acute management of hypertension as well, and how how to monitor and follow up our patients. And the importance of having this information is to ensure that as much as possible we can reduce cardiovascular related morbidity and mortality among our patients. The ultimate goal is to reduce complications as much as possible and ensure that patients who are newly diagnosed with hypertension can continue to live, have a normal quality of life regardless of their diagnosis. So, by keeping their blood pressure low, we'll be able to achieve this. And then, by keeping their blood pressure low, we'll be able to achieve this. And then knowing the right medications to give, the right tests to do as well, we'll be able to achieve overall cardiovascular reduction among our patients. Thank you very much.